All right, let's jump right in. Today we're doing a quick and dirty journal club on a topic that you've probably heard some buzz about, metformin. Now, we all know it's the bedrock of type 2 diabetes treatment, but what if it's doing more than just managing blood sugar? What if it's actually protecting our patient's eyesight? Let's take a look at the evidence.
You know the drill. Your patient comes into the clinic and they're dead set on stopping their metformin because of something they saw on the internet. It's a constant battle, right? Trying to counter that Dr. Google misinformation about a drug we know is safe, effective, and cheap. Well, this emerging evidence on vision protection might just be the new, compelling talking point we need to help them stay the course.
So let's get into the data that really kicked off this whole conversation. We're going to start by looking at this really unexpected connection that researchers found between taking metformin and the risk of age-related macular degeneration, or AMD. Now, the first thing you need to know is that this isn't just some small one-off study. This is a signal that keeps showing up again and again in these massive, large-scale analyses. We're talking about data from literally millions of patients. And when you see a signal that consistent across populations that big, you've got to pay attention.
So what's the bottom line when you pool all that data together? You land on this number, a 14% lower odds of developing AMD, an odds ratio of 0.86. That's a statistically significant finding, and it's what's getting everyone so interested. It suggests there's a real protective effect going on here.
And this table really drives home the sheer scale we're talking about. I mean, just look at the HA analysis. That's over 2.5 million people. Now, you'll see the exact numbers wiggle around a bit from study to study. Holtz et al. Even found a much stronger effect, but the key takeaway is that the signal is consistent. They all point in the same direction. Taking metformin is linked to a lower risk of AMD.
Okay, so seeing a link in the data is interesting. But as clinicians, we always want to know the why, right? An association is one thing, but having a plausible biological mechanism, well, that's what makes it really compelling. So how in the world could a diabetes drug be protecting the retina?
And what's so cool is that it's not some brand new mysterious mechanism. It looks like metformin's greatest hits, the things we already know it does systemically, also work beautifully in the eye. It flips on the AMPK pathway. Think of it like the cell's master energy switch, and that triggers a whole cascade of good things. It helps the cells clean up waste, it dials down oxidative stress and inflammation, and it puts the brakes on abnormal blood vessel growth. It's basically targeting the core drivers of AMD.
All right, this all sounds pretty fantastic, but let's pump the brakes for a second. This is a journal club after all, so we've got to put on our critical appraisal hats. As exciting as this all is, we absolutely have to understand the weak spots in the evidence before we go changing our clinical practice.
And you don't have to take my word for it. The authors of these very studies are the first to point out the giant caveat. As Ha and colleagues put it, every single study showing this effect has been observational, and that means they are all subject to bias. They're telling us flat out, we need randomized clinical trials. This slide really lays it all out. It's the evidence we have versus the evidence we need. Sure, these big real-world observational studies give us a powerful signal, but they can never escape the classic problem. Correlation is not causation. There could be other factors, other confounders at play. To actually prove that metformin causes this benefit, you need the gold standard, a randomized controlled trial. And for this specific question, we just don't have those yet.
So while we're waiting for those RCTs, we have to bring this conversation back to the here and now, to our clinic on Monday morning. And that means placing this potential new benefit in the context of what we already know for certain about long-term metformin use. Because any potential good has to be weighed against known risks.
And at the top of that list, of course, is vitamin B12 deficiency. This is non-negotiable. It's not a maybe, it's not a theory, it's a proven, well-established fact of long-term metformin therapy, and that's exactly why the ADA guidelines tell us we need to be monitoring for it.
And make no mistake, this risk isn't trivial. The data shows that just being on metformin more than doubles your odds of becoming B12 deficient. And for so many of our patients, the ones on higher doses for many years, that risk skyrockets to almost 3.5 times higher. It's a serious clinical issue we have to stay on top of.
Now, here's where the plot really thickens. Because metformin isn't the only drug in the story. The whole landscape of diabetes and organ protection is being completely reshaped by the absolute explosion of GLP-1 receptor agonists.
And for our day-to-day practice, this is a critical comparison. When you look at huge electronic health record studies that put GLP-1s head-to-head against metformin, well, the results are pretty striking. It looks like the GLP-1s are actually outperforming metformin for eye protection.
We're seeing significantly lower risks for dry AMD and even more dramatic risk reductions. We're talking 40 to 50% for primary open-angle glaucoma. So, after all that, where does this leave us? We've got this promising but unproven benefit for metformin, a well-known risk, and a new class of drugs that might be even better. How do we synthesize all of that into practical advice for the clinic? Okay, here's the 4-step game plan. Step 1. For that patient who wants to quit, reassure them. Remind them why metformin is first-line therapy, it's safe, it works, it's inexpensive. Step 2. We can now cautiously mention this potential vision benefit. Frame it as interesting but still early data. Step 3. This is a must. We have to continue our routine B12 monitoring. And finally, Step 4. We need to keep the big picture in mind and acknowledge that for some patients, the stronger data coming out for GLP-1s might influence our treatment choices.
And really that all leads to this final pretty provocative question. For decades, metformin has been the undisputed king, the first-line therapy for type 2 diabetes, no question. But as we get more and more powerful data on agents like GLP-1s protecting hearts, kidneys, and now maybe even eyes, are we watching the beginning of a challenge to metformin's crown? Are we moving to an era where we choose a first-line drug based not just on A1C, but on total, multi-system organ protection? That is the billion-dollar question we're